Well, hi, Cynthia, and hello to the GPO Optho group. I'm Shachar Tauber here in Springfield, Missouri, the entry point to the Ozarks. And we've just completed a long day in the OR. I am the chair of the Department of Ophthalmology here at Mercy and been here for the last 20 years, and really have enjoyed the opportunity to help our patients here. I want to take a moment before I go any further to congratulate Cynthia, because when she started GP Optho, uh, it was an impressive amount of work that she had to do, and she talked with us throughout it all. And to hear that you're over 1,000 strong, and to see all that you have, I took the liberty of, as we work in a major health system, our GPO is pretty established, and I was impressed by how well in such a short period of time you've been able to grow yours. So I certainly will take advantage of doing this if you'll let me join to
Absolutely.
see where the holes are in our GPO, and perhaps we can help our patients and our staff here. But I've been here 20 years. I came from Yale. I was a professor there and was asked to come here to help build the refractive program. And from refractive surgery, I took over research here. We've done a lot of clinical research over the years and continue to do this. And it's been trending from cornea to ocular surface to cataract and back and forth. And we've been involved with some incredible work with artificial intelligence recently. And really, when I was asked to talk about the Cassini and essentially the integration of our OR with our Catalyst femtosecond laser, I was really pleased, because this is something that has been going on now. I believe we're in our 5th year of that marriage between Cassini and the Catalyst. So this has been very good, and we certainly use it every day we're in the OR. In fact, today it helped me tune in things very comfortably, and I'm happy to speak to this. Look forward to seeing everyone in Los Angeles soon enough. So tonight we're going to talk about how Cassini has really changed the way we do cataract surgery. In 2013, we started a program here where we stopped doing cataract surgery with standard manual techniques. And we now, in 2013, converted 100% or close to 100%. Some patients couldn't fit under the femtosecond laser and other rare things, but we now have 3 femtosecond lasers, and we are over 50,000 surgeries with the femto. In the early part of COVID, we were asked to consider the Cassini, and I had a lot of wonderful conversations with members of Cedars-Aspen who were Cassini experts, and I really was intrigued by this device. And it was exciting to see that Johnson & Johnson felt very strongly about the Cassini, and as they introduced their software and updated their software, the Cassini became a part of it, and we jumped on it because we wanted to do something that would be better in the operating room for our staff, for our patients, for the surgeons, and really better for our results. And really tonight we'll talk about how that integration and the ease of use and the ease to the staff allowed us to become better in our results and allowed us to really improve the premium channel of our cataract surgery. We live in a rural part of the country. Penetration of premium prior, first 10 years that I've been here was under 5%. Really wasn't much, and I was somewhat jealous of some of the other practices, but understood that we were dealing with perhaps a different population. But I can say now that with the increase that we've had in the last 5 years or so with the integration, that we're really impressed by this, because we're not doing anything but just good surgery. There isn't any marketing. I hear my marketing from my dear friends that are down the road in their practices, and am jealous that they can sing the praises of this, but we just are growing well. And this, all I've said is because we've gotten better confidence. The lenses have gotten better. The femtosecond laser has gotten better. And the Cassini really is the bridge to that for our practice. So if we can go on from here, I'm looking at the guy who needs a haircut here for a long time, and I'm glad I got one before this meeting. So thank you for that picture. This is the Cassini Ambient. This is what's presently sitting in our operating room right now, not in our clinic right now. In fact, I think we have an order for a second one because we are pushing the boundaries of how much it can do. We work very well with the Cassini team. They have been to our practice many times and have been very wonderful in support. A lot of the work can be done through the internet for service, and really they've been a delight to work with. Excellent educators for the physicians as well as the staff, and excellent troubleshooters. It's what is this device? Device is a point-to-point ray tracing topographer. It uses 700 LEDs, which is quite impressive. The multicolors really is wonderful and has many uses, including management of dry eye, we're finding, and really using it as a dry eye screen for patients coming for cataract surgery. We need in our present cataract surgery the ability to accurately and directly measure the anterior and posterior cornea to figure out what tonal corneal astigmatism is. That's very critical in getting our results to be better, and this device has it. The postoperative refractive surprises when you do a cataract surgery in a complex patient. And today, an example of that was a radial keratotomy patient that came in and was a candidate in the end, in my opinion, for a toric lens. And when everything lined up, and the Cassini being the device that really was the umpire for us for many years, it did the surgery flawlessly. It lined up in this patient, and we're very excited. So we think the reduction of postoperative refractive surprises has really helped us expand the breadth of the toric lens for us. It's very quick, instantaneously gets an image. The eye movement is really minimal in this device compared to some of the others. 1.5 minutes of chair time has been reported. I don't see that we are any slower than that, and our staff seems to like it. And it integrates with our EMR, it integrates with Veracity, and certainly it integrates with our femtosecond lasers. And the three of them that we have are fed Cassini data on a daily basis. So that's the device. And if we look at this next slide that's coming up, that's what it looks like. To the left is what sits in the clinic, and 1.5 miles down the road is one of the three of our femtosecond lasers. We have the luxury of putting our femtosecond lasers in the operating room, so you can see that we'll operate in the bed that you see there, and it just swings over to the left, and that's where our microscope is, and that's where our phaco unit is. So really the patient comes into the room with the cataract and leaves with a multifocal or toric lens properly aligned, and all in, by laying down once. It's really helped us. It's how we started. We realized that we're an outlier, but when we traveled the world and saw some of the practices we wanted to mimic, one of the things that we learned from Burkhard Dick and his group was placing it in the OR would be very helpful, and we had that luxury. So essentially, the Cassini is over the internet communicating directly to the femtosecond laser. So that data is downloaded by the team the day before surgery. So after I left the OR at 4 o'clock, the team is downloading tomorrow's surgeries for the next surgeon. And that's putting in the Ks, and that's putting in all the data necessary. And that really works very well. We rarely hear of a glitch going on there. And usually the glitch is related to the IT department here at Mercy, and really not anything that is between these two devices. So this marriage is 5 years old, and it's something that we continue to work with as the operating systems continue. And I see that my good friend Alan Graham's on the call here. He always comes up with wonderful surprises, and we have told him, and he understands that we will continue with the Cassini as we have had that great experience with it. So his software includes the Cassini from the beginning and going forward. So that's what it visualizes, those two pieces. And we can go to the next slide.
Before we go to the next slide,
Sure.
we have two questions. One is you mentioned that you're also using the Cassini to detect dry eye disease. Obviously, it's so important to identify, optimize before we take them to the OR. How are you exactly using the Cassini to figure out the level of dry eye or whether a patient has dry eye?
Well, Cynthia, it's a great question. We've been searching for that perfect test that can consistently give us a dry eye diagnosis that's not just qualitative but quantitative. And I've been down with osmolarity. We did much of the research on the MMP9 detector here. We have all gadgets, and we still have to use our brain to come up with the right thing. And each patient has its own concoction or cocktail, I find. But one of the things that we use is there's a video component to the Cassini that we can analyze because of those LEDs and really see what the tear film looks like on that surface. So we will take the video, and it's important that you analyze it, and when you're finished with it, you discard it because it does take some space. But it really gives us a sense, especially when we use an IOL Master 700 and we use the Galilei G4 for our topographical. And when there isn't a good agreement, it's our first pause, and our staff knows that to make sure they took a video of the Cassini for us to see. And then there's a protocol that we use for dry eye treatment. So we'll have a pre-op visit before we see the patient, and in that pre-op visit, the decision to start them on an immune modulator, lid hygiene, oral therapy, hydro-eye being one of the things that we are excited to work with, and bring the patient back and look at that video again and see if there's any sort of agreement. Finally, when we have agreement, like this patient I told you about with RK, there was 3 measurements for this patient for us to feel comfortable that yes, a toric lens consistently at different times of the day is matching up. And over the 5 years I have, and at least 3 of my surgeons have used the Cassini as the final referee that is looking at the others, and this is the number that we use. So that's been very helpful for us to do that. And I would recommend that those are going to ASCRS, go to the Cassini booth and have them show you that video. It's really, I didn't know about it for the first couple of years, and they showed it to me. I'm like, this is helpful for me.
That was a great response. Thank you so much. And one other question before you move on is the data transferability. Is that done automatically, or does it have to be manually inputted by a technician?
The data is automatic. We suffer from super paranoia of being hacked by Russians here at Mercy. So what can be done in most clinics, because they're not being hacked daily like we are, apparently, is it goes over the internet and it'll populate into the laser. We bring something called the USB, and those of you who don't know what that is, back in prehistoric days, I'll look for one on my desk. We carry that over in an encrypted key, and that's what's brought over. So I brought over what I did today when I came to the OR this morning at 6:30 is I brought over the key for tomorrow.
Got
The
it.
surgeon before me brought it, and the Thursday surgeon brings over the Monday. I have argued till I'm blue in the face with the IT people. They speak IT, and I get lost in the language. But it's worked for us. But I think in a real practice that controls all its things, the connectivity, through the Ethernet and through the cloud is fantastic.
Thank you very much.
So really the three pictures down below are what we're talking about. Operational efficiency, more confidence in the procedure. Those two, you add that one, the one to the left, the one in the middle, gives you more premium procedures because you're comfortable speaking to them. You're comfortable talking to patients. And we'll use this in post PKP cataract surgery and with a degree of confidence with this, and certainly the post refractive patients. And the scar patients where we can work with this. It's really been a big part of how we built up this practice is the Cassini marriage to the femtosecond laser. So what does that mean by increased operational efficiency? There's been studies, 9 surgeons with great experience with the Cassini have figured out that up to 18 minutes of time is saved from pre-op measurements all the way to surgical conclusion. The question asked earlier is direct pre-op data entry is now an automated done either by a USB integration or more commonly through the internet. And one of the things that we learned, and as a refractive surgeon, we learned a while ago, is that iris registration is so critical to our results. If we think about LASIK surgery, when I had my LASIK in '99, you look straight ahead and the surgeon marked you with a big fat pen and then put the Heine beams out to measure them. And then you can imagine how much artwork there was there, right? Not just literally, but figuratively, just to get things to line up. With iris registration, it first came into the excimer lasers where there is a rotation. The brilliance of that was wonderful. Immediately, we saw an improvement in astigmatism because we were on target. And we've been begging for this in the femtosecond laser. And Alan knows how much we begged for this. And he came back in the middle of COVID goes, I have your answer. And this was in the Cassini that it could bring us iris registration. So the elimination of manual ink markings and aligning the patient interface is really where this 18 minutes comes from. If you think about it, for us, we mark and the Cassini, and the Catalyst has an interface which tends to land right on top of the marks. So we have to use a special pen so it could be seen, but it is really, I hated it because you had to sit there with all this fancy equipment and guess where that mark was, and it had run off or it was obscured by the patient interface, and you weren't as accurate as you wanted to be. And the marking was uncomfortable for the patients. We'd have to put a speculum in some patients. And then we went, in the intermediate step between 2013 and 2020 was Callisto for us, which came out of the IOL master. And Callisto was a big step forward for us, but it required marking, but at least gave us something for us. And it was good, and it's still our backstop for certain things. But when in San Francisco, the academy before this one, so right before COVID, Burkhard Dick said, I've stopped using ink, which was almost sacrilegious. I know how precise Burkhard is. He goes, no, with the Cassini, it just gives me the alignment and it works. It's almost fail safe. You'll capture an image at the time of femtosecond laser, and that's what I use all the time. It just guides me to put my marks on the cornea. So that's where the 18 minutes comes in. That's where the operational efficiency, and your staff loves it when they don't have to play artist because they always are apologizing that one mark is higher than the other. And you realize that there's got to be a better way. So this is the better way. So when we take a look, the next slide should talk about where this 18 minutes breaks up to. 6 steps before Cassini, 4 steps with Cassini and the COS, now 7.0 operating system of Catalyst. The surgery day is the treatment plan being entered in, the ink mark, and then there's two ink marks. And I remember now trying to figure out how's there two ink marks. One is for the staff to put it in. The second one is for the surgeon to line the ink mark up to the catalyst so that you could move the astigmatism in the OCT image. And that really was where you were guessing for me. So that those things go away, and now you get your diagnostics. The planning gets lined up directly in as it's brought in for tomorrow already, and then the toric alignment is only done after the procedure is completed, and you look at the marks that the femtosecond laser put based on the Cassini guidance, and you just line up things. It is simple, and we use Callisto to take a photograph of that. And what we do is we compare it to the lines of Callisto to what Cassini put down in the cornea. And there are times when it doesn't match. And we've been looking at these patients, and the Cassini has been right for us. So that's, the 18 minutes saved. And I think on the bottom is the 15 minutes before I go to bed going, did I get it lined up right? It should be included there. But they didn't listen to me on that one. But you worry about it. I think the accuracy is there. Efficiency and incision accuracy is really the key to this slide.
Dr. Tauber, we have another question that just came in. What is the iris registration success rate in the OR when using the Cassini imaging?
It is reported up to 100% in certain practices. We're sitting at about 94%. And I will tell you that in part, you have to, this is a beautiful device, and you can't put newcomers, because we put our newest techs in testing, usually in OCT, because it's point and shoot and helps retina. But when they get into this type of testing, that's where we're realizing that there needs to be a sense of ownership of the results. So as we're looking to get that number closer to 100%, that's our first place to look at. We've looked to make sure that it's not related to the operating system of the catalyst and not an issue with the Cassini. Both teams have been very good in spending time with us and really looking at this. And I think it is a learning curve for the technician, and we're all suffering, I believe, across the country with a high turnover of staff. And this part breaks my heart, because you're taking people that have never had eye experience, and you're saying, okay, I want to be within half a degree of my accuracy. And they look at you like, why is this important? The ones that get it, we promote as much as we can. And I think the most important thing you do at the end of a month when you're looking at your results is you go to the Cassini and the testing people in general, but the Cassini people, and say, it's because of you we have these results. And they're getting it because we'll send patients back for second eye for reasons of multiple reasons why we do remeasurements, and they'll tell the staff how good their vision is. And they come to me and say, they're really happy with what you did. I said, no, you did it with this device. So that 94% to 100% is really how good iris registration is. And it's quick. In the OR, it really doesn't slow the flow of our femtos, and we do it for everybody. I'm not the fastest surgeon. My fastest surgeon is doing 30, 35 femtos a day. He's managed to figure it all out very quickly. I don't have that gift. I tend to talk too much, I believe, between and kind of marvel at the technology. And we always have someone visiting us when I'm in the OR. So I talk too much. So it can be done. It's a surgeon problem. So that's really, this is true, that it does make you faster. It makes your staff, get the flow right, and you feel more comfortable when you put that lens in that mark. We'll go on to the next slide. And this is data. This is real stuff. You can see on the left one, diagnostic summary, you really have a summation of the anterior and posterior and total cornea. And we use total cornea for data entry into the Toric calculator. I'm using these numbers. I will look at the other numbers, and if there's a huge discrepancy, then we'll bring them back. We'll look at the video we talked about earlier of the tear film. We'll bring them back. Sometimes there is, because there's a corneal scar there, and you have to basically sit down there and say, which is right? Which one do I trust the most? And being conservative, you don't want to overcorrect astigmatism. But I love the access that we get from this. I love the fact that the data is here. The surface indices in the bottom right of the diagnostic summary really gives you a lot of good things. The higher order aberrations, really helpful in picking for a multifocal or extended depth of focus lens for us. Really interesting in the refractive patients, and you get to see patients who've had LASIK in the 90s versus patients who've had LASIK in 2020 under the newer lasers, and how that number has gone down and really is speaks to refractive surgery on the surface. The surface irregularity, another indication that you might have something to deal with ahead of time. Really good diagnostics here. And you really get the green, the boxes right above that, quality factors. So it's communicating. It has the potential to go forward. The flex iris registration is there. I don't use that routinely, but I know it's there, and it's very helpful in demonstrating the accuracy in the iris registration. The display on the Catalyst OCT includes that as well. So you do have excellent diagnostics here, and I would recommend to your audience to spend some time with the Cassini folks. They really know their stuff here. I'm very impressed by how passionate they are about this. And when we challenged them, they came back and showed us that they are first in class. So we'll go on to the next slide. More confidence in procedure. That's really the key to making my life happy. The accuracy reported in the literature at the ASCRS in 2020, Doug Koch and Wang, really those guys down in Baylor are quite brilliant in this. We've done some astigmatism surgery with them before Cassini with intrastromals, and I'm very impressed by their stuff that they're doing. Accuracy within 0.8 of a degree, 3 times better than manual marking, and surgeon-dependent manual compensation. That is probably what causes post-traumatic surgeon stress, is that I'm manually compensating for something, and it's the ink mark. The work that we had done on when we introduced COS6 to surgeons was these big blotchy ink marks. And it's like, where would you put the center of this? And that goes away. The laser marks that our Catalyst puts on the cornea is within 0.6 of a degree, more than 5 times more precise than manual ink marks. Again, quite good. This is what you want with accuracy. This is where you can feel comfortable, not just in the toric IOLs and the multifocal torics, but your arcuates. And using these arcuates, we use them for up to 3/4 of a diopter of astigmatism usually, and getting that to work well is quite impressive. We'll go a little bit more at times, but we try to keep our arcs to 45 degrees maximum. And we'll use intrastromal for them. In our work with Baylor, we found that they're under 45 degrees to be equal. And I like the fact that the intrastromal are not creating any ocular surface concerns. there's certainly no reason not to do this if you're aware of the ocular surface and doing anterior penetrating. And the question that came up earlier was, what's the registration? It's close to 100% with the 9 surgeons involved in the study. We are using that as a target for ourselves, and we think it's a learning curve for our staff. And we'll go on here unless there's a question. Okay, what does that mean? More premium procedures. You have a happy OR, you have staff that gets reinvigorated every time they see a post-op, and now you start putting in new lenses. So we've now had Odyssey now for 8 months and really has improved a lot of our accuracy and satisfaction for patients. And we bring the staff in when we are getting these results, and it's across 5 surgeons. This is the first time I've seen a unity about the multifocal and extended depth of focus, especially in the toric one, where they feel comfortable. So the talk in the clinic is just staff saying, we've got a new lens. This might be good for you. I've got a good test. Nothing is better than your staff saying this before you walk in the room, right? This is exciting for us. And when they can show you, I use this test, then the patients, because you're coming in to see a patient, you have to go through a whole examination. You're looking for pseudoexfoliation, zonular issues, ocular surface issues. Is the retina okay? And then you're trying to gauge at the end of this, should I put a multifocal lens in? And meanwhile, your 80-year-old patient who's been dilated, sitting in the dark, is asleep and just wants out. But if they come in because the staff member said it in a visit before and they gave them information, this makes my job easier, because now they go, why can't I have this? That's much more of a LASIK conversation, because the LASIK patients come in wanting it. The cataract patients just want to see better. What their definition of better has changed. We're helping that. This device is helping that. The confidence is great. I don't know any of my surgeons that do not use the Cassini on a daily basis. I know that the upgrades that we get are better each time, and the marriage between Cassini and Catalyst are so good. And we've been instrumental, I think, in getting the J&J team to understand our passion for Cassini-driven data. And we're excited. The new software that's coming out, that's exciting. That Alan, my lips are sealed. I'm not going to say a word about it. But it really is, we made a bet in 2013 that femto is the right thing to do. And a lot of people thought I was crazy. And then when we came with a program to give it for everyone thought I was going to bankrupt not just my hospital, but the Vatican. And we haven't done anything but indeed do well with this. And finding a real good aphakic space where we could park a lens and park it in the right place is really where we are right now. So I'm very proud of this. I'm honored that you guys asked for our thoughts about it. The next slide will go over some other thoughts from around the country. Jared Younger, who I've only got to know recently, is saying 40% of his toric volumes, basically saying it's related to Cassini. Eric Donenfeld, who's taught us all for years, and being a medical student visiting Manhattan Eye and Ear in, I don't want to say when, 1987. And he has always taken me under his wing. And when the Cassini came out, we were both on the platform for Catalyst. And he says, this is going to be a game changer. And for his practice, it is. My partner, Wendell Scott, really took to this, and he loves the science of it. He can explain those data sheets all day long, but he's right. It did triple our volume. It was a very modest volume before, but now we feel very comfortable. And we use it again for multifocals, extended depths, torics, and for arcuates. And I use it for arcuates on my corneal transplants. And we customize those, and it's essentially Cassini driven for marks. So again, since this is not CME, that's super off label, and I don't want you to take that as that's the right thing to do. But for us, it seems to work for these patients that we can do intrastromal arcs to reduce surgically induced astigmatism from grafts. But this is from a point of view of how do I offer better quality of lenses to my patients. I think the Cassini was a good decision 5 years ago, and it will be for us going forward. I
Dr.
think
Tauber, these numbers are really astounding
aren't
among
they?
such busy cataract surgeons. I mean, 40%, 25%, and triple the toric lens volumes. These are not little numbers. These are big numbers. You also mentioned that you're not just using it for toric, but also for presbyopia correction. Do you take factors into consideration such as mesopic or photopic pupil size or angle kappa? And if yes, does the Cassini provide that group of data for you?
The pupil size has been argued back and forth for so long and goes back to LASIK. And I don't know that I've ever gotten an answer that I could consistently look at because we've done patients. Unfortunately, most of our cataract patients were struggling to get the pupil big enough, right? It's not a day that goes by that I don't have IFIS and other things. And in lenses such as the light adjustable lens, you need to get, and there are patients who can't get that way. So we're fortunate as opposed to the LASIK populations about pupil size. You do need a certain amount of pupil for the multifocals extended depths to work. We haven't done that, but you certainly can do it in the Cassini by getting some of their measurements are there. We use angle kappa. The IOL master before we had Cassini had something very similar to angle kappa. I'm forgetting what it's called, the CA angle. And talking to the lens people, and in particular Patricia at J&J, she shows us study after study that angle kappa really didn't consistently measure. Now, one of the things that we do use is what I showed earlier is the higher order aberrations. And our cutoff really is about 0.6. I like to feel comfortable at about 0.4, 0.4 to 0.6. I need to hear motivation that this is, I never wore glasses, and now I became 40. I wore not only reading glasses, but the next year I got distance glasses, and now I have cataracts. I'm never going to do this again. And I'm like, this is what you're going to have to deal with. Your higher order aberrations are on a high end where we feel comfortable. And in that case, a different lens makes sense. If you're above that modified monovision, makes sense. But that's been the first thing that's put on the IOL master is what the HOA is off the Cassini for me. That's what we're using.
Great. Thank you.
Well, I think the next slide is a thank you. It is. It's a beautiful Cassini slide. So this is good. It's exciting to see, Cynthia, really, as I said from the beginning, that this GPO is really run faster and stronger than anyone imagined when you first started it. Kudos to you for your organizational skills. The people on this conversation, physician-wise, she's a go-getter. If you ever have a chance to see her host a panel, which I got to see most recently in Hawaii, she ran it so well, so entertaining, so informative, and she was on time. She was the only one in Hawaii that wasn't on Hawaiian time, and everyone on the panel was done. And it's always, you've been doing Hawaii panels for years, and it's always one I like to catch.
Thank you. I have one final question for you, Dr.
Absolutely.
Tauber. Do you recommend the Cassini for surgeons who are currently advanced technology or premium IOL users who want to enhance their conversion rates? Or would you recommend it for somebody who, let's say, has only rarely dabbled in premium lenses but wants to start? So which surgeon is the Cassini best suited for?
We fall into the second category. We were the ones that dabbled into it, kind of dragged our, the painstaking mechanism to get a premium lens in a health system like ours made it so that it was more difficult to even have a conversation. So we dragged our feet. So for us, having a Cassini really said, hey, the science is here, the accuracy is here. So for a new surgeon coming out from the protection of residency and fellowship, having a device like this that you can grow with and and have a team that is consistent. The people that work with us have been very good, consistent, and excellent teachers. That is, I would say, this is one of the devices that's worth putting in your OR. The other ones that are successful and have a conversion rate 30, 40%, they're keeping data somewhere else. There's someone chewing their data and giving them results, because there's no way they could have that high penetration if they weren't getting good results.
Mm-hmm.
They're following it. So they're doing something else. Is it as efficient as ours? Is where you're not marking it all? I don't know. They must be doing something, but to say that someone is with an ink pen each time and is getting results that we're getting with Cassini, I have a hard time believing in it, because I struggled with it and I never could get a good answer with it. And it really, there's something better out there. There's something better out there. And, we had Aura, and Aura was wonderful, but it took a lot of time and you had to make a decision on the table. And sometimes it didn't give you what you thought was right. And there were some very well-known Aura surgeons that kept consignments up and down for each patient, and it wouldn't work for us. And some of them have great results and still swear by the Aura, and I respect their surgery and I respect their results, and I think for them it works. For me, if I was looking to get, if I was looking to open up another satellite for Mercy, I would say what works for us in femto and premiums is this marriage. It's very good. The support is good. The device has a relatively quick learning curve, and the OR loves it. The throughput's there. The data entry mistakes, flipped axes. I mean, these things happen to us. I hate when it does, and it's a visit back to the OR or it's an excimer laser or whatever it is. But these mistakes happen when they shouldn't. So the point that we don't spend much is that the manual entry of keratometry, the manual entry of where the 180 is something that I don't think needs to go forward anymore. I don't believe it. For me, I wouldn't encourage a new surgeon to do that. I think there's devices here. They're married to femtosecond lasers beautifully well. The science of these companies is involving these devices because they're making lenses. And if the lenses are put 10 degrees off, the lenses don't work. They've got these lenses not to rotate anymore. So it's not a matter of the lens rotated. It landed in the wrong place. Having these marks are beautiful. These three little, this little slash that we put in matches with the three dots. And the optometrists that see them get to see how accurate things are. And that's another compliment that you're getting as you're building relationships or you want to rebuild relationships is, wow, there's a lot of accuracy here going on. The femto gives you a beautiful capsulorhexis, and now it gives you, here's the marks on the toric lens, here's the marks on the cornea. I'd recommend you get them in within about 6 weeks, because by the time you get to 3 months or so, it's real hard to find those marks. But at one day, our optometrists that are doing same days, they'll hold me accountable. It's like, you're 5 degrees off. And, sometimes on the Flomax patients, when the pupil comes down, you have to really get that picture quick and show them, no, you're not seeing something right. It's where it needs to be. So I think to your question is, both groups do well. One group is successful and they have some secret sauce, but I don't believe it's ink marks. I think it's something else that they're doing. Callisto was very good for us, but we did better with Cassini. And ink marks, not so good. And Aura for some surgeons are great. Some surgeons think the light adjustable lens is the easy way because you have an eraser that you can come back later on and do. It's certainly something we just like the lens platforms we have. It works well for us. I love the quality of our implants and the acrylic that we use, and so for us, this is a good marriage. And happy to help anybody. Happy if anyone's in the Ozarks wants to catch a show in Branson where country western music singers come to retire. You're all welcome in Springfield.
Well, thank you so very, very much, Dr. Tauber. What an incredible presentation, sharing your personal experience married to the Cassini technology was a fabulous presentation. Thank you again.